All right, welcome to the studio. We have with us today Dr. Darren McGuire, who has come from UT Southwestern, where he's been a faculty member since, I believe, 2001.
Exactly.
Yeah, and Darren has been a favorite of ours here at the Texas Heart Institute, and he's always on our invitation list for lectures. And we're so glad to have you here in Houston, and we're glad the weather accommodated your flight and all. We've had a lot of cancellations, but the weather here is pretty good. No real obstacles
better
this
than
year.
Dallas.
Yeah, exactly.
Better than Dallas for sure.
So Darren, we followed your career as a clinical trialist and as a clinical scientist, and really supported as well by your tenure as an executive editor for Circulation. Now I guess you're in your 7th year running. That's a big log of work on that front, I'm sure. You've had a bird's eye view, really, of the formation of this whole field in cardiology, which is cardiometabolics, or what would you call it? What would you say?
It's interesting, you know, we're falling on the cardio-oncology domain,
Yeah, I
right?
know.
Which I completely disagree. I think we get that backwards because we're oncocardiologists, because the root word is cardiology. So Dr. Braunwald has been very vocal about this. I edit a companion textbook for him. Our original title was Diabetes and Cardiovascular Disease, but he encouraged us to make it diabetocardiology.
Diabetocardiology.
So that's what he calls it. Now, the ACC and the ADA are partnering on cardiometabolic training programs that will ultimately, we believe, be formalized training programs to work in this space of the nexus of cardiology and metabolism. And it's not just diabetes, we're also encompassing lipid management and obesity. And so diabetes, lipids, and obesity kind of form the buttress for this.
They're the bulk of our risk group.
Right.
I mean, so for, in my age group, similar to yours, we've seen the development of this entire field develop before our very eyes, quite honestly. And so as following this kind of program, I'm a little bit more comfortable with taking the approach that this affects my patient's outcome, and I'm willing to take a step in there, but I got to tell you, my colleagues that are above me, they're not comfortable in that venue.
Yeah,
so how are we going to get people to adopt really important research findings into daily clinical practice?
Yeah, we've taken the approach. I oversee the Parkland Health System cardiology clinics. That's where all the fellows have their continuity clinic experience, and so we've taken the approach to go from the young guns upward. And so we've trained our entire fellowship now that these drugs, the SGLT2 inhibitors and the GLP-1 receptor agonist, independent of glucose control. We're not embarking on glucose management here, but we're using them independent of glucose for their cardiovascular benefits. And I tell you, our fellows are knocking it out of the park. Our statistics in our cardiology clinics at Parkland are, I would argue, are among the very best in the country. Not exactly true across the street at our university practice, where all of our age folks are practicing, but we're seeing a rapid uptick, and especially driven by our heart failure transplant group, now that we have heart failure data. For some reason, the ASCVD outcomes data didn't really resonate, but now we've seen these drugs so beneficial, so easy to administer, at least the SGLT2 inhibitors, that my colleagues are really coming on board quickly. I always am proud when one of my colleagues pages me and says, hey, or texts me and says, hey, I want to start an agent. Here's the patient characteristics. Is this right thing to do? How would you do it? And so they're asking for help. The GLP-1 receptor agonist in our cardiology clinic is a little bit more difficult. And in parallel, we've discovered the great utility of our clinical pharmacist. So in my clinic at Parkland, in the cardiology clinic, if we want to start a GLP-1 receptor agonist, we simply put a consult to a clinical pharmacist. Please start GLP-1 and titrate it.
So they come in and discuss it, and they show you how to do it?
They do it all virtual. The pharmacists can do it all virtual. The injections are so easy with these pens.
The tiny needles.
And they're tiny needles. They don't hurt. You don't have to cleanse the skin. But what you need in that domain is you need first to find the one that's most affordable for the patient. The pharmacists take care of that. Then you have to start at a very low dose, stay on that low dose until the nausea goes away, and then titrate up. If you titrate fast, you're going to lose the patient. And so our pharmacists are very well educated in this aspect. And so basically our patients go off and they come back to see us 3 months later and they're on the target dose of drug, and it's kind of automated. It really engages the pharmacists too. They really enjoy being that part of clinical management.
What we find here is that we have a hard time getting the drugs through the pharmacy because there's such a shortage of the GLP-1s and getting it covered, as you said. I'm actually really interested in, you may not know this, but I nearly became a nephrologist. So I'm kind of interested in the whole protect the heart, protect the kidney. And I see that the nephrologists seem to be a little bit behind on the adoption of these things. And so for the protect the kidney, you said it's a class effect. All the GLP-1s do it. And the bottom line target for the GFR is 20 or is it 30? What is it for GFR?
Yeah, I'm glad you asked that. A lot of people are very confused about the GFR cautions or contraindications. We are so accustomed across all of medicine to having contraindications or cautions based on GFR because of safety concerns. What the reality for the SGLT2 inhibitors, the eGFR threshold has nothing to do with safety. There's no concern about safety.
Because it's not being renally cleared?
Well, it is being renally cleared, but it's probably cleared in other mechanisms. But the reality is the reason that eGFR threshold is in the SGLT2 inhibitors is because they each came to market to control blood glucose. As eGFR wanes, the glucose effect wanes. But what we've seen in every trial, the lower the eGFR, there's almost an interaction. There's a greater cardiovascular benefit.
So you don't think there's any floor?
There's no floor. In fact, the trials that have recently been completed, patients randomized to the SGLT2 inhibitor who entered the trial because of advanced kidney disease, they continued the drug until they started dialysis. The day they start dialysis is when they stop the drug. And so they were using it down below 15, below 10, 5, and there's no safety concern. That's
super important to know. And I think that, well, clearly we need to get the word out. And I think that part of the benefit, part of the apprehension is just lack of knowledge, obviously. And people are afraid of, knocking off a kidney.
Bad disease.
And certainly in a cohort of patients that have really no clear benefits in this renal population, hitting the renal protection, could be a very nice target for education.
Right, and and getting back to your original question, I think most agree right now that probably 20 is where we at least have data of safety. I think a lot of people, if they're tolerating it above 20, they would sustain it below 20. Probably wouldn't start it below 20, but I don't think there's a safety concern. That's a data-free zone.
That's really
But I think across the board, if we just give the message, keep it simple, anything 20 or above, you can use them without caution.
Okay, good.
And that's what we're doing. Again, I work in the Parkland health system. We have formulary restrictions on a lot of medicines, and the only restriction we have now for the SGLT2 inhibitors is an eGFR less than 20. And so everybody in the system can prescribe.
And type 1 diabetes.
It's not specified, but I think most people would understand. What is specified is type 2 diabetes with ASCVD, heart failure of any etiology, and chronic kidney disease of any etiology, as long as eGFR is above 20.
Perfect. So you've gotten like 70% of the patients that come to cardiology clinic by nailing that.
Almost everybody that we see has some eligibility criteria. And we go back, we try to find athero anywhere to justify the prescription. And so we go back to old non-cardiac CT scans. And if there's a calcium documented calcification, then we say that that's athero. Not yet clinically relevant, but probably.
Well, now with the advent of all these calcium score tests that people are coming in with, you've got, it's pretty.
People are asking
for it. And it's pretty available, and everybody wants one, and I'm all for it. For many reasons. It really helps people to understand that they are at risk, and it helps them to be motivated to take the medicines. These medicines are kind of easy sells, especially the GLP-1 inhibitors.
Right, the benefit of the weight loss, the patients love it. Patients who are overweight or have obesity, they love it.
So in your role at UT Southwestern as an important clinical, instructor and part of your research program, how do we keep people on the track that you did? And is it going to be possible for us to train the next generation? Because there are so many more demands on the fellows' time, and it's hard to get them involved in research and staying in research. What do you think about that?
Yeah, a very difficult question to answer, and it depends on what you consider research. So the work that I've done has been almost exclusively large-scale randomized international outcomes trials. I got into this space because I got connected at a very young age. So my first year of fellowship, I was working with Rob Califf and all the faculty at the Duke Clinical Research Institute, and I was literally working on these mega trials even as a first-year fellow. But I think what's really important and what catapulted my success is I also simultaneously did a master's degree in clinical sciences. And so I have formal didactic training in statistical methodologies, epidemiologic trial designs. We had an entire semester of the regulation of drugs. So the FDA directors came down one at a time to Durham and taught us. And so in connectivity, you just have to be selfless early on. I tell you, I spent about a decade doing work on these trials with no potential for academic output. And that's a challenging proposition, right? If you don't make it, you don't make it. And then, I spent all my time learning this trial stuff, but I didn't learn how to read an echo, right? And so I have no billable skills.
But I'm worried, really, because how we're going to support, financially for fellows to pursue this additional training that I really think is super helpful. And I really, as a program director, I really want to reward fellows or applicants that follow their intellectual passions, because people that are intellectually curious, they're more engageable to do something that is more beneficial to mankind, I think, in a lot of ways, and that we don't swallow up the intellectual pursuit of scientific progress by the demands of the clinical volume, which is, as you know, a bigger burden for our medical centers. And you and me, we've kind of made it through, so we're going to be good either way. But I'm worried, having people have some protected time so that they can pursue academic interests, because they're important.
And on top of that, I think it's really important to get the education. We have a very structured basic science pathway through a tenure track where there's mentorship and checkpoints along the way. A lot of places don't have anything like that for the clinical investigator. At Duke, I was the benefactor of a program that had started the year before, so the Master's in Clinical Sciences program. So I actually got the training, which really allowed me to do better research, right? I know how to design a trial. I know the statistical issues. And we have a parallel pathway now at UT Southwestern.
Oh, that's really good.
And we have an application process. If you're approved by application, it's completely funded by the university.
Oh, that's great.
And it's an additional commitment of time, for sure. And some fellows, it takes an additional year of training just to work that in. But I think what's a real mistake is to let somebody jump into the clinical research domain having no training at all, because they're destined to be frustrated and fail early on. And learning it pragmatically, sometimes you don't have enough time to recover from those early bad experiences.
Yeah, I've been a recipient of the good part by being part of the Harvard Clinical Effectiveness Program, which is the similar program that many of the TIMI investigators do. And we have a similar clinical scientist program here that we encourage our fellows to do. But you're right. I have had several fellows that have, really good fellows, that have pursued that pathway and made it into rigorous academic curricula. So it is actually fundamental. I'm just worried how we're going to be able to sustain that long term, with the demands that people have. So in final, 4 years ago, we had lunch at a symposium that was hosted here, and I asked you, what do you think the mechanism of the SGLT2's benefit was? And at the time, this was about 4 years ago, you were pretty honest, and your comment, I kind of remember, was basically, we're not really that sure.
We have no idea.
And how have we, because clearly the class effect is enormous. It's super beneficial in almost every category you've checked. So you've hit a home run as an academic gambler by picking the right horse, my friend. And how is it that you think that they're really working? Yeah,
it's a great question, and I was really enamored for a long time, for probably 5 years. I just rested all my beliefs on the kidney, on the restoration of tubular glomerular feedback. So this is complex physiologic mechanism that's coordinated by the macula densa that senses urine electrolytes and adjusts vascular tone of afferent arterial. It's known that SGLT2 inhibitors immediately restore normal arteriolar tone from a dilated artery to a constricted one, so that drops glomerular perfusion pressure. I still believe that that probably is at least part of, if not the total mechanism of kidney protection. But that has nothing to do with the heart.
So it reduces hyperfiltration.
It reduces glomerular perfusion pressure and glomerular hypertension, preserving the glomerular health.
Right.
And then it also inhibits the renin-angiotensin-aldosterone system, so you get blood pressure favorable effects. You also get sympatholysis, and so you get a sympathetic nervous system withdrawal, as opposed, all diuretics stimulate the SNS, but these diuretics do the opposite. And so
you raise the EPO levels.
I think the critical things of the kidney, and then what happens when you inhibit proximal sodium reclamation that's metabolically cheap because it's an osmotic gradient, now you're relegating sodium reclamation to more expensive metabolic mechanisms through the sodium hydrogen exchanger and through epithelial sodium channels. And because of that, you induce regional tissue hypoxemia that's sensed by the fibroblast, and that induce EPO production. And so you're increasing red cell mass to overcome this tissue hypoxia. So
you need to start screening the Ironman competitors for SGLT2s.
Funny you say that, because my colleague Ben Levine at UT Southwestern is on the International Surveillance Committee.
Oh, yeah, it needs to be
He sat through
screened.
one of my lectures, and he immediately went and he had two really creative ideas. One is we need to add this to the performance-enhancing screening drugs.
I was thinking of that.
Because it's blood doping.
Exactly.
Right? The second thing he thought immediately, so I need to let the Department of Defense know, because if we ever have to immediately deploy troops to altitude,
this is the fastest way you can get.
You give them SGLT2 inhibitors on the way, and they bump up their hematocrit.
You've shown us the effect is super early.
It's really fast. It's within a week.
I totally.
So you don't get hypoxemic.
I have a daughter who's a distance runner, so as soon as I heard the first lecture you gave, I was thinking to myself, that's a fast way to dope the athlete, and with really hardly any side effects. Interesting. Well, we're just super glad that you came, and you brought all your wisdom, and I was literally sitting in the audience taking pictures of your slides, because I use them to talk to the patients.
I'll share. You can have my slides.
I really just share with the patients what the data shows, because the more you explain to the patients, the more they will be encouraged to, follow your recipe, because they're really at a disadvantage, because there's so many drugs that, if you're a diabetic, you're like, oh my gosh, how many more things do you want me to do? And it is kind of overwhelming, and they have to pick and choose. So I literally go through the list with the patient: live longer, feel better, doesn't do anything. I don't know. Well, Dr. McGuire, thank you so much for joining us today, and we are immeasurably thankful for all your wisdom and for coming to visit us so frequently. So thank you so much, and have safe travels back to Dallas.
Thanks for the invitation. I really appreciate it.
Rock and roll.